Hello, everyone, and welcome. Today, we're diving into a really fascinating group of drugs. Think of them as hackers for our nervous system, drugs that know exactly how to find and flip the off switch on one of the body's most important systems. So let's get right into it.
So let me start by asking you a question, a bit of a riddle. What do you think connects a beautiful but deadly plant, an anesthetist's most important tool in the operation theater, and that little patch you might stick behind your ear to stop feeling seasick? Sounds like a strange mix, doesn't it? Well, the answer is what we are discussing today, anticholinergic drugs.
So here's our plan for today. First, we'll get to know the body's brake system. Then we'll meet the OG, the prototype drug, atropine. We'll see what happens to a body when you take the brakes off. We'll meet some of its more specialized cousins, check out all their medical uses, and finally, and this is very important, we'll understand why these powerful drugs have to be handled with so much care.
Okay, first things first. To understand how these drugs work their magic, we first need to understand the system they are targeting. You can think of it as the body's built-in rest and relax mode.
This system is called the parasympathetic nervous system. You've probably heard its famous nickname, the rest and digest system. A really simple way to think about it is as the body's main brake. It keeps your heart beating nice and slow. It helps you digest your food. Basically, it keeps everything running in a calm, steady, chilled-out state.
Now here's the crucial part. Anticholinergic drugs do one simple but incredibly powerful thing. They block this entire system. So if the parasympathetic system is the brake pedal in your car, taking these drugs is like reaching down and cutting the brake lines. Just imagine that. Every single effect we're about to talk about comes from this one single action.
All right, let's move on and meet the big boss, the prototype against which every other drug in this class is compared, atropine. And it's an all-natural product. It comes from plants in the Solanaceae family, including the very famous and very poisonous Atropa belladonna, also known as deadly nightshade.
Now, the most important thing to understand about atropine is that it's not very picky. It's not a surgical tool, it's more like a sledgehammer. It blocks all the main subtypes of muscarinic receptors, M1, M2, and M3, which are basically the control panels for this whole brake system, spread all over your body. This non-selective nature is both its greatest power and its biggest problem.
So, what actually happens when you block all these receptors at once? What does a body without its parasympathetic brakes on feel like? Let's take a quick tour, system by system.
Okay, look at the heart. You block the M2 receptors there, you cut the slowdown signal, and the heart rate just speeds up. That's tachycardia. Then you have smooth muscles like in your gut and your bladder. The brakes are off, so they become lazy and relax too much, leading to constipation and making it hard to pass urine. It blocks M3 receptors and glands, so everything dries up. Your mouth, your sweat, secretions in your lungs, and in the brain, if the dose is high enough, it can cause all sorts of chaos, excitement, confusion, even hallucinations. Your body temperature also goes up because you can't sweat to cool yourself down.
And the effect on the eye is a perfect illustration. See, normally, the parasympathetic system keeps your pupil nice and small. Atropine blocks that brake, so the muscle that constricts the pupil just relaxes. Now, the opposing muscle, the one that pulls the pupil open, has no competition, and your pupil becomes wide open. We call this mydriasis. This is why it causes sensitivity to light and makes it hard to see things up close.
So as you can probably tell, atropine is a bit of a blunt instrument, isn't it? It just hits everything. And this big problem led scientists to develop what we now call atropine substitutes. Basically, smarter drugs that are designed to be more selective, to cut the brake lines only in the specific places we want them to.
Let's take a look at hyoscine, which you might also know as scopolamine. It's a very close relative of atropine. And this table shows the key differences. But look at the CNS effect. This is the big one. While atropine excites the brain, hyoscine actually depresses it. It makes you drowsy. And this effect is exactly why it works so well for motion sickness, answering the riddle from the beginning. Now here is some really clever chemistry. How do you stop a drug from causing all those messy side effects in the brain? You change its chemical structure. Atropine is what we call a tertiary amine. This structure lets it cross the blood-brain barrier very easily. It's like it has a VIP pass. But look at these quaternary compounds, like ipratropium. Their structure is different. It's bulkier. This makes them unable to get into the brain. So you get the effects you want, say in the lungs, without any of the confusion or delirium. It's a brilliant solution. And this selectivity is really the key to how useful they are. So now let's look at how we actually use these drugs. How we purposefully cut the parasympathetic brake lines in medicine for good reasons.
from the OT to the eye doctor's clinic.
One of the most classic uses is before surgery. An anesthetist will give a drug like glycopyrrolate to cut the brakes on the glands. This dries up all the saliva and bronchial secretions, making sure the patient's airway stays perfectly clear. It also blocks reflexes that could cause the voice box to spasm, and, very importantly, it protects the heart from slowing down dangerously during surgery. It's an absolutely essential tool.
And the list of uses just goes on and on. We use them to relax the gut muscles to relieve painful colic. The inhaled versions are absolute lifesavers for patients with COPD, opening up their airways. They're used to dilate pupils for eye exams. They can be used to treat a dangerously slow heart rate. And maybe the most dramatic use of all, atropine is the direct, life-saving antidote for poisoning by things like nerve gas and certain types of mushrooms.
But, and this is a very big but, a drug this powerful has to be respected. The line between a therapeutic dose and a toxic dose can be very, very thin. So we have to talk about what happens when things go wrong.
There's a very old mnemonic in medicine that perfectly captures the signs of atropine poisoning. Every medical student learns this, and it is chillingly accurate. Dry as a bone from no secretions. Red as a beet from flushed skin. Hot as a hare from fever. Blind as a bat from the dilated pupils. And mad as a hatter from the delirium.
And each symptom in that saying is a direct but massively exaggerated effect of blocking the parasympathetic system. You have a racing heart, a feeling like you're burning up inside, terrifying hallucinations. It's a complete system overload that, in very severe cases, can lead to the heart and lungs just shutting down.
And this brings us to the absolute no-go areas, the situations where these drugs are completely forbidden. For a patient with a condition called narrow-angle glaucoma, giving this drug can cause a sudden, catastrophic rise in the pressure inside their eye. It can cause blindness. And for an elderly man with an enlarged prostate, blocking the bladder can cause an acute, painful inability to urinate. Both of these are proper medical emergencies.
Whew! We have covered a lot of ground, haven't we? So, what is the one big idea, the main takeaway point I want you to remember from our discussion today?
It's this. Anticholinergics are incredibly powerful tools. They give us a switch to turn down the body's entire brake system. But their very power, their ability to act everywhere at once, is also their biggest limitation, because it creates that long list of predictable side effects that we always have to watch out for.
And that leaves us with a final thought to ponder. We've seen how we went from the sledgehammer of atropine to more selective drugs. So the question is, as our science gets even smarter, can we one day design the perfect anticholinergic? A drug so precise it acts like a laser beam, cutting just one single brake line in one target organ, giving us all of the benefits with absolutely none of the side effects? Now that is the future of pharmacology.
Thank you for listening.